Hi, my name is Dr. Amir Garakani. I'm the Director of Education at Silver Hill Hospital. I want to thank you for joining us for our grand rounds today. We'll be having a speaker, Dr. Robert Klitzman, speaking about what patients can teach us about religion and spirituality. In a moment, I'm going to pass over the microphone to my colleague, Cheryl Bundy, who's a chaplain for Silver Hill Hospital, who will introduce our speaker today. Before I do that, I want to go over some housekeeping issues. First, if you want to ask any questions during the Q&A part of this presentation, which will come at the end, please look at the link located on the top right of your screen. It'll look like two speech bubbles with a question mark. You can submit your question there and during the presentation anytime. And at the end, Dr. Klitzman will do his best to answer all questions during the time frame of the event. Finally, if you want to submit for CME or any type of credit, please do so at the end. When we're under that same section in the Q&A, there'll be a publish section with a link so you can submit your CME credits. Now I'm going to hand it over to Cheryl Bundy. Cheryl?
Thank you, Dr. Garakani. I'm Cheryl Bundy. I'm the chaplain and spiritual counselor at Silver Hill Hospital. Here at Silver Hill, spirituality is part of everything we do and every patient that we meet. Whole patient care, mind, body, and spirit is part of our ethos. I had the pleasure of hearing Dr. Klitzman speak at Yale Medical School last year about the importance of spiritual knowledge and awareness in patient care by clinicians in a world where the definition of spirituality is rapidly changing, and it informed a lot of what I do. And I have the pleasure of introducing him today. Dr. Robert Klitzman is a professor of psychiatry at the Columbia College of Physicians and Surgeons, the Joseph Mailman School of Public Health, and the director of online and in-person bioethics in the master's and certificate programs at Columbia. He has written over 140 scientific journal articles, 9 books, and numerous chapters on critical issues in bioethics regarding genetics, neuroscience, doctor-patient relationships, and other areas. He is the author of numerous books, including The Struggle to Make Human Research Safe, Am I My Genes?, Confronting Fate and Family Secrets in the Age of Genetic Testing, When Doctors Become Patients, and In a House of Dreams and Glass, Becoming a Psychiatrist. Dr. Klitzman has received numerous awards for his work, including fellowships from the John Simon Guggenheim Foundation, the Russell Sage Foundation, the Commonwealth Fund, the Aaron Diamond Foundation, the Hastings Center, and the Rockefeller Foundation. He is a member of the Empire State Stem Cell Commission, the Ethics Working Group of the HIV Prevention Trials Network, and served on the U.S. Department of Defense's Research Ethics Advisory Panel. He is a distinguished fellow of the American Psychiatric Association, a member of the Council on Foreign Relations, and a regular contributor to the New York Times and CNN, and now our Grand Rounds. Thank you, Dr. Klitzman.
Well, thank you very much for that very kind introduction, and thank you so much for inviting me. It's delightful to be here and have a chance to speak with you today. And as mentioned, I see this as an interactive session, so please feel free to ask questions. And as mentioned, I'll try to answer as many as I can. And also feel free to reach me afterwards if you have other questions or things you think about afterwards. So I just need to advance my slides here. Can everyone see that? So this is a controversial topic. There are social taboos against discussing religion. It's often said that in polite conversation, don't talk about religion or politics. There are agreements that many of us have, regardless of our beliefs, but there are also disagreements and perceived disagreements. And of course, we're coming to this issue at a time when there's been a lot of political and religious divisiveness in our country. There are often, or generally almost always, no right answers for a lot of these issues. And medicine and science have historically at times been seen as mutually antagonistic. So this is a picture of Galileo, who said that, among other things, the earth goes around the sun rather than vice versa. This went against church teachings, and he was forced to recant by the church. Freud, one of the founders of our field, also saw religion as an illusion, as a dangerous illusion at that. But I would argue that this topic is important because spirituality and existential and religious issues are important to many of our patients, if nothing else. And also providers and patients are increasingly of differing religious beliefs. We also have a lot of physicians and providers and patients who have non-Western religions about which many of us don't know as much as we might and perhaps should. And I'm going to draw partly on my own experiences and tell you a little bit about how I came to this topic, and then go into some of the research I've been doing on this recently, and also research that I've done as part of some of the other projects that I've studied in the past. So when I was a young man, before I went to medical school at Yale, I had the opportunity to go and study a disease called kuru in Papua New Guinea. And kuru at the time was a very rare, obscure disease. We didn't know what caused it. Since then, we have found that it's caused by a prion, which turns out to be the same as that which causes mad cow disease, or the same family of infectious agents. Mad cow disease only happened a few years after I did this research, though I was there in the early 80s, and mad cow disease really happened in the late 80s. But the time was obscure, and we knew that the disease was spread by cannibalistic rituals in this tribe. It's a neurological disease, and when someone died, the women had no other meat in their diet, and the women and their young children would cut up and consume the body. One woman said, "This way I'll always have part of my mother inside of me," for instance. I would say, but this disease is, it killed up to 90% of the women in the area and 2/3 of the population. And they believe that the disease was caused by sorcery and could be cured by sorcery. They believe that spirits affect many, many things, everything that happens to you, whether when you walk outside it's raining or not, if you're in the field. This is all due to the spirits, if you've hurt the spirits or offended the spirits or pleased them, etc. I would say that they believe that a sorcerer would take something that belongs to you, wrap it around a stone, cast a spell on it, and they dig up stones and say, "See this stone here? This is the stone that killed my mother." And I'd say, no, kuru is caused by a little thing like an insect. And they'd say, "Well, show it to us." And I'd say, "Well, it's too small to see. You need a special machine." And they say, "Well, what does it look like?" And I'd say, "We don't know." And they'd say, "Have you seen it?" And I'd say, "No." And they say, "That's just a magic. Here's this kuru stone is what killed my mother." Similarly, they had counter sorcerers, healers, who said that they could cure the disease. And I said, I met some of these curers, these healers, and I said, "Well, who have you cured?" And they pointed out various people, and who all looked perfectly normal to me. And I said, "Well, what's the treatment?" And they said, and I should say that because the disease had wiped out so many people in the population, anyone who had a headache thought they had the disease and were then cured. So I said, "What's the treatment?" He said, "Well, for 2 weeks, you're not allowed to drink water, eat salt, touch a member of the opposite sex," and I give them some herbs and I cast a spell on them. So I said, "Well, is there anyone you didn't cure?" And he pointed to one guy who I thought had the disease, and he said, "Well, him." And I said, "Well, why didn't the treatment work?" And he said, "Very simple, he didn't follow the treatment. He drank water or ate salt, etc." So they also believe that there were special areas in the forest that were waterfalls or ponds that were places belong Masalai, places of the spirit that no one was allowed in, that I realized served as sort of nature preserves. Well, at the time I thought this was all ridiculous. This was just made up beliefs. This is just mythology. I believe in science. Science was truth. That's the attitude I had when I began my medical training. But over time, I should say, I at one point had a sister who died 9/11 and was grief-stricken for weeks, and no amount of psychotherapy really helped me. But thinking about how nature goes on for me, to me was very reassuring. And I began also to wonder how other doctors deal with these issues when they get sick, how they look at spiritual issues, and so I did research that led to a book called When Doctors Become Patients, in which I interviewed 75 doctors who became patients with serious conditions, mostly cancer, heart disease, HIV, other things like that. When I'd say, what was the change that you felt? What did you learn that you didn't know before? A lot of them talked about religious and spiritual issues. So one doctor, for instance, an elderly gentleman, said, patients used to say to me, "Doc, would you pray for me?" He said, and I go, yeah, whatever, and I poo-poo it. He said, and then I became a patient, and I realized how important those issues are and how we just completely ignored them and paid no attention to them. So I began to look into this more and became interested in this, and then I'm talking with you today. So there have been a few books by doctors in which spiritual, religious, and existential issues arise. Sherwin Nuland, the late Sherwin Nuland at Yale, Richard Seltzer, who was at Yale, Atul Gawande today at Harvard, have raised these issues and talked about how important they are, especially at times of death and dying, but at other points too, patients dealing with substance abuse, patients dealing with chronic illness or pain or psychiatric illnesses, but many questions about it remain. And what I found in doing research is that these topics make doctors uncomfortable. So things are improving slightly in medical school, but not enough. 48% of doctors, studies show, feel uncomfortable with religious and spiritual issues. 44% feel that they don't want to talk about it because patients will be uncomfortable. Turns out there's no evidence of that. Might be a bit of projection, perhaps. 70% of dying patients want their doctors to ask them about their religious beliefs, but only half of those who want it get it. But interestingly, in studies, even those who get it, even if they didn't want it, are much more satisfied with their care during their hospitalization. 72% of cancer patients say that the medical system supported their spiritual needs minimally or not at all. Nurses tend to be more aware of these issues than doctors, and chaplains play important roles. But nationally, if you look at hospitals, studies show that they only see about 4% of patients. And as I mentioned, there are political divides, and we see this even, and religious divides, and we see this even in, there have been various bestsellers. There have been books like Heaven is for Real and Proof of God that basically say, these are often near-life experiences that people have had, and they say they went to heaven or they met God, who was, a guy in a white gown with a long beard and a white chair, etc. And on the other hand, you have books like The God Delusion by Richard Dawkins, who say that religion is all nonsense, it's harmful, etc. So there's this divide between, is this heaven for real or is it all delusionary? And so I've looked at these issues in a number of studies recently, and then gone back and looked at some of the interviews I've done in studies in the past, interviewing patients and doctors with HIV, substance abuse, genetics. I've done work, as mentioned. I wrote a recent book called Designing Babies, How Technology is Changing the Ways We Create Children, in which I interviewed people who are involved in IVF and assisted reproductive technologies. And there, for instance, many people said, many women who were infertile say, I just think, God intended for me to have a baby. Somehow this is going to work. Or people would say, well, I guess I wasn't meant to have a child. So even their religious and spiritual issues come up. So there has been work in the sociology of religion that talks about the 3 B's: behavior, belonging, and belief. That people vary in what they believe, how they behave, and whether they feel they belong to a religious institution. But what I found in doing research is even within these categories, there's a lot of variability. So I've been doing interviews most recently with chaplains as well as with patients and doctors. And of course, many patients ask, why me? This comes from, or very famously in the West, was asked by Job in the book of Job in the Bible. Why is this happening to me? God, why have you done this to me? And of course, there God is testing Job to see if he would give up his beliefs. This was really part of a bet from the darker angels. Patients ask even when they realize that these questions are irrational. They say, I know I shouldn't wonder why me, but I do. So I've actually began to think about this more, and I apologize for the small size of this, but I think I've come to realize that issues of why me are quite complex. It can mean different things. So a bad event occurs and patients then commonly ask questions. What caused it? Can I stop it? Can I avoid it? Can I have avoided it? Etc. Patients consider explanations. There are facts. And they're unknown. So even when I've interviewed patients at risk of Huntington's disease, for instance, when I did the book, Am I My Genes? Confronting Fate and Family Secrets in the Age of Genetic Testing, a number of patients said, well, I know I have Huntington's because I have the gene, but why did God give me the gene and didn't give it to my sister? Or why did God give the gene to my sister but not to me? So even we have an explanation, a medical explanation. It's human nature, I would say, to sort of ask wider questions. These are, I think, partly the way our brain evolved, is to think about wider questions, not just why did X happen, but why, if X happened because of why did Y happen? And I think with questions of why me, patients are in fact really asking one or more 4 different questions. Either why am I singled out? Why me? What did I do? Why me? Did I do something wrong? And is this punishment? Why me? I mean, why am I being punished? And of course, these are sort of slightly different questions, though obviously related. As I mentioned, patients seek not only physical answers, but often metaphysical, moral, religious ones. These answers could be emotionally satisfying to us or others. We work on them. Psychotherapists play a big role in helping patients, quote, get over questions of why me. But patients say, they'll realize, it's important to focus not on what you may have done wrong in the past, perhaps, if you're seeing this more as punishment, but what we can do now to cope best with the situation that we're facing. But people often remain frustrated. They go back and still ask why me, or they may feel better and then they'll relapse or have another problem and then again sort of re-enter this cycle. So these are sort of ongoing issues. And I think, again, that's important to understand the complexity of what may be involved. So in terms of answers, patients vary. I interviewed a chaplain recently who said that he felt he was agnostic, but there are 1,000 kinds of agnosticism and 1,000 kinds of atheism. So patients vary. Some are religious to start. So one doctor I interviewed, for instance, as part of the book I do, When Doctors Become Patients, said, when on call, I used to ask the priest to pray for me. When she was sick with cancer, went to Lourdes. She was very religious to start, and in some ways, though, even now became more religious. Many people become more religious, particularly if they hadn't been particularly religious or grown up with a religion and then sort of gave it up, or lapsed, Catholics, whatever, or Jews or Christians or Protestants, and then return, though often with a difference now when they become ill, often reconsidering their beliefs. And what struck me is the number of people who mix and match beliefs. So a lot of people say, I was raised ABC, fill in the blank. I married someone who was ABC, fill in a different one. We then joined a CDF, temple, Protestant, Unitarian, Buddhist, whatever. Then we gave all that up. Then I was a Buddhist, then I was nothing. Now we started to go to services that were whatever it may be. So I think in our modern society, people are ecumenical. People mix and match beliefs, switch, etc. Many people have religion without belief, of course. So there was a woman I interviewed, a physician actually, who said had grown up in the Hasidic community, but gave that all up, said, I don't believe any of this shit, she said. But when she developed cancer and it was unclear how she'd do, people from the Hasidic community came and visited her. And they said, we want to bring you food and pray. And she said, well, that's all right. You can do whatever you want, but I don't believe any of this stuff. They said, that's okay, but we just asked that, when you go home, and there was a little bit of a tone of if you go home, that you light Sabbath candles. So she said, fine, but I don't believe any of this stuff. But she said when she went home, she now lights Sabbath candles every Sabbath, even though she told me she doesn't believe any of this stuff. She don't believe any of this shit. So again, there's religion. Obviously, the rituals have some meaning to her, even if she, quote, doesn't believe, whatever that may be. People may have religion despite themselves. So there was a very politically active physician I interviewed who was a Marxist and had been very radical things in his youth and was involved in global health issues. But he said when he developed cancer in the hospital, he said, I felt like there was a tree rooted inside of me that connected me with the earth and was reaching up in its branches. And at first he said, maybe I was delirious, but I wasn't delirious. And he didn't know quite what to make of this. And I think a number of people have said things like that to me, that often they find themselves praying, even if they don't believe in prayer. And again, I think this speaks to also how difficult it is for people to understand their own beliefs or put labels on them, etc. A lot of people say that they're spiritual but not religious, particularly younger people. They have beliefs in higher powers, and of course this is sort of the language of AA, or has been used and in AA, is often used in AA and is very helpful to many patients. It's often not well defined. Sometimes it's related to beliefs in nature. And then people feeling that trees go on, that nature in its mystery and beauty, every flower having its own beautiful way of being in the world, that in itself reflects something of, quote, the divine. What struck me also is a number of people who say they are not spiritual religious, but I felt others might say they are. So another man I interviewed had a science training in college and now did other things, but now he was faced with a serious illness and said, I believe in the third law. He said, I don't believe in any of this stuff, religion, but I believe in the third law of thermodynamics. He told me that energy is neither created nor destroyed, it goes on. And to me, that sounded very spiritual, even though he said, no, this is science. Some people I thought were spiritual, but not realizing it. A doctor I interviewed said, I'm, an atheist, but I believe that if I treat every patient with the best science and the best devotion I can, I'm doing my role here on earth, which to me, again, sounded very spiritual. Other people talk about having just humility before the unknown, but not believing anything beyond that. And again, I think these are all spiritual notions and suggests how inchoate and complex a lot of these issues can be. So someone may say, I don't believe, and that can mean one of a number of different things. I think that humans do seek connections to larger sources of meanings. For some people, that's through their children or through work or through art. But for many people, even there, I think there are spiritual elements there. But again, this raises questions of spirituality and religion. I should say that religion comes from the Latin word religio, which means ties, linkages, often to an institution. Whereas spirituality comes from the Latin spiritus, which means breath. So we inspire, we have respirators, but it speaks to something of the invisible, the immaterial, our spirit, our breath, particularly for the ancients, though we know it's oxygen and nitrogen and carbon dioxide. To them, it was the breath, it was something that was not material. So it was a more general notion. Another thing I found quite interesting in the research I've been doing is the ubiquitous of free-floating beliefs. So sort of folk beliefs. So people say, well, what goes around comes around. Or I mentioned with genetics, with HD, why did God give me the gene, etc. People may not associate with religion or spirituality, but suggest something beyond us in a way. And issues of luck come up. And so the Greeks believe that there were the three fates of Clotho, Lachesis, and Atropos. These were mythological figures. One would create the yarn that would make our lives. One would measure it, how long our life would be, and the third would cut it. But luck, I found, as I began to look into it, has interesting psychological, philosophical, anthropological perspectives. Lots of patients talk about, I had bad luck, I got cancer, or I just wasn't lucky, and I relapsed, whatever. These are folk beliefs. Relatedly, many people have folk beliefs of fear of jinxing things, knocking on wood. We all make a wish when we make a birthday, when we blow out our birthday candles. And again, I think these are ubiquitous things in our society that suggest something about what we believe. And I should say, when I went to college, atheism was big, sort of Freud and Marx, etc. I think people are more open to beliefs. Many people are in many ways. So when thinking about luck, I realized luck too is quite complex. So for any particular condition, whether it's you get cancer, you get COVID, your mother dies, you get in an accident, you ended up getting hooked on a drug. Is luck involved? Yes or no? If it is it good luck? I was lucky, I was unlucky. When? Can fluctuate. Philosophers and psychologists say we tend to say that luck is involved when we don't have responsibility for it or control. So if I say I was unlucky, the assumption is that I didn't have responsibility, I was out of my control, it wasn't something I did, it was luck. But what I found is that individuals differ in whether they feel they understand the source of luck. So for some people, it was God, I was unlucky, God must have wanted this to happen, or I was unlucky, just something in the cosmos made this happen. But also people often feel they themselves are unlucky. I'm an unlucky person. or I'm a lucky person, and not related just to a choice about a particular thing, but about one's larger being in the world, as it were. Of course, some of this may be related to depression, etc., but I think these beliefs are out there. And again, it's partly, do you deserve blame or not? Are you to blame? Do you deserve to be punished, etc.? And the other thing I found is that how much luck, but also I should say religion in general, is a social phenomena where other people say, people I've spoken to say, he thinks he was unlucky. He just makes stupid mistakes. Or, if you had worked harder, you wouldn't have been in that. If you done the right thing, you wouldn't have been unlucky on that test. You would have done well on the test. So I think these have implications for us as providers, for practice, for education, for research, etc. Also recently, there's been a growing movement of people who, when asked if they are, quote, Catholic, Protestant, Jewish, none of the above or other, say none of the above, or other or none of the above. And these people have been called knowns for none of the above. They're commonly lumped together, though, I found. So in the literature, it often includes people who are atheists, agnostics, others unsure, but what I found is that it's quite heterogeneous. And also, as I mentioned, people have trouble describing themselves. So what struck me is a lot of people say, well, I kind of believe, or I sort of believe. And I think there are several sources of these uncertainties. Beliefs fluctuate over time as crises come and go. Many people, when faced with a major crisis, an illness, a death of a loved one, they may begin to face these issues and then, quote, go on to life as normal, quote unquote. There is no evidence to support beliefs. We're talking about these sort of things we can't see. There are components that people interpret differently. So omnipotence, how much does God control? These are theological notions. Omniscience, does God know what's going to happen? Does God control things or not? People pick and choose beliefs. People interpret these in ways that might not be consistent. They may ponder questions even if there are no answers. And so people aren't sure how to categorize their beliefs, how to describe their beliefs, how to use terms. They may have personal terms. So people may say, well, I'm spiritual, religious, atheist, agnostic, not sure, Catholic, Jewish, Protestant, whatever it is. And what they may mean by that could be very different than what someone else means by that. And people therefore say, I kind of believe, I sort of believe. They change over time. They often define themselves in relation to others. So one man I interviewed said, well, I'm an atheist. I said, tell me about that. He said, well, my parents are strict Catholics and I'm not that, so I'm an atheist. Actually, I'm not really an atheist, I'm more of an agnostic, but I say I'm an atheist just because I'm sort of, giving it back to my parents and say they're wrong. So again, the social context affects a lot of this. So I think we need to recognize limitations and uncertainties in public discourse and also patient's discourse, how we categorize things. Measurement is very hard. There have been scales to measure religiosity, but a lot of them are limited for obvious reasons, I think. And of course, in political discourse, people use these terms saying, those are heathen, those are atheists, they're bad. And I think often many people share more than they think. Of course, I think a lot of people use drugs for many reasons, one of which often I would deposit, and we can talk about this, is to have a sense of something beyond themselves, often to get away from the brutal facts of their lives. And I did some research on club drugs and ecstasy a while back. And what I found is that there are people often used ecstasy, MDMA, they call it the love drug, as a way of connecting to other people, of feeling part of something larger than themselves, even just going out dancing with a room full of people on a Saturday night or early Sunday morning. It's a way of connecting, and I think it sort of comes from a place that for other people leads to a search for connections that we might think of as more spiritual. I think opioids as well, again, connection, escape, a sense of despair, but I think people are looking for a larger sense of meaning, even if it's fleeting, something beyond themselves. And as I said, many people get that through religion and spirituality. Some people also, or instead, etc., may use substances for that. Another thing I'm quite struck with are new forms of religion, sort of online communities. So we're now talking on Zoom. Everything's happening on Zoom because of COVID. But even before that, I think there there have been growing online presences of religion. I think it's important. I think we're at a pivotal point in our country and in the world, particularly our country, about religious and spiritual ideas. I think through Facebook, many people find like-minded individuals who share values, offer support, saying, here's a picture of a beautiful sunset I saw, or here I just had a grandchild or a child, or just bought a new dog or cat, or it's our anniversary, or, you know, my mother died, my dog died, my sister died. So people are sharing meaningful experiences with others. That is something we used to do in a religious institution. We'd go there on a Saturday night, Saturday morning, or Sunday morning, and we'd share things with people whose values we share as well. So there's a wide range from formal online churches to informal, various subgroups. I one woman I interviewed who has a child with a serious congenital condition from an Orthodox community, said her closest friends now and connections are other Orthodox Jewish women with children with congenital abnormalities, and they meet on a Facebook group. And I thought it was quite striking to me that you would think, this is my naivete, you know, Orthodox Jewish woman with congenital problems, so her community in Brooklyn would be most important to her, but instead it was other women on Facebook who are also Orthodox Jewish women. So again, people are finding various subgroups, and I think this is why many fewer people are attending overall a bricks and mortar church. And I think that also has implications. I think that connections are important. I think other kinds of groups can take the place of a brick and mortar church, but again, there may be various trade-offs. So in medicine, obviously, beliefs also play a role in prognostication. It turns out that a doctor's own religion affects how long doctors think patients have to live. There's also complementary alternative medicine. Many patients want to take a more holistic, more patient-centric view. A lot of the doctors I interviewed for the research on when doctors become patients said at first patients would tell them they're doing CAM and they'd say whatever, and then they found themselves when they got sick doing CAM, doing things that they said I'd never recommend for my patient or support it, but I'm busy doing it and feel it's helpful. So there are questions, does spirituality affect health? It can certainly help with coping, providing a sense of hope. There's a lot of data that religion buffers against depression in many ways. There is evidence showing that attendance at religious services lowers depression and suicidality. Some of these studies, I think, have not completely separated out sort of which comes first, but there are very strong associations and some suggestion of causality in some of the research. I think certainly spirituality and religion can help with coping and social support. Perhaps it may just be a placebo effect, but that can be very powerful. Positive thinking, there's also research, can aid wellness, anxiety and depression, can impede the immune system, of course. Obviously, this is important, 12-step programs. There's a literature about intercessionary prayer, which is there are people who argue, who feel that if I pray for you and you're sick, even if you don't know that I'm praying for you, that my prayer will help you. There's no evidence to support that. There's evidence to the contrary, but there are people who continue to believe it, just FYI. And even with prayer, I found, and again, I apologize for the complicated nature of the slide, but I found there are various types of prayer. So there's prayer by whom? People of different backgrounds and experiences with religion, whether they have experience with religion and organized religion in the past, whether it was good or bad, what the nature was, what the disease was, how stressful it is, how much help they feel they need. But then these things can all affect what one does, patients do in terms of prayer, but then patients vary whether they pray to an explicit God or just a non-specific implicit entity, whether they pray for themselves or others, whether they are explicitly religious, non-religious themselves, what they pray for. Some people pray for just helping to get rid of the disease itself. I hope my cancer goes away. Other people just hope for more psychological coping, for strength, for reassurance, for guidance. Some people pray for forgiveness and redemption, perhaps for past behaviors. They may feel guilt, you know, they feel that they've let people down. Often people with substance abuse, as you know, may feel that they've done things wrong. They've wronged people, they've stolen in some cases. They've used people for drugs. Some people, you know, engage in sex work for drugs. They may feel guilty about that. And they may feel they may have contributed to their disease. in various ways and see disease as possible punishment. If they get HIV or hepatitis, for instance, they may engage in bargaining. There are questions what to say when you pray. So some people say a set prayer. I say, whatever the blessing that's been used for centuries in a religion, or some people may have extemporaneous prayers, whatever my heart says. There are differences how hard one prays, whether it's out of desperation, when. Some people do it regularly, some people do it very regularly, some people do it more only after disease, some people vary, doing it only, quote, when I need to pray. With what expectations I found varies. So whether people feel it works, some people feel my prayers were answered or unanswered, some people think that doesn't matter. Whether they need to change the outcome, some people feel it's helpful but not sufficient enough itself. And for some people, it's a metaphor for hope. I just pray I'll recover soon. I just pray that my father would stop yelling at me, right? So they're not using prayer in the sense of, I'm going to say the following blessing, but just things that we want from the world, perhaps. Where some people pray mostly religious institutions or at home, in nature, or elsewhere, how consciously. Some people, again, say, I just found myself praying. What to call it, not all people call it prayer. And again, for some people, it's a metaphor. And again, I think there are effects psychologically, feeling better. I think a lot has not fully been studied on this. I think it can decrease aloneness, guilt, reduces some sense of having, quote, sin, could potentially help reduce depression, anxiety. And to other people, the attainment of outcomes doesn't matter. And again, I think these are important issues for healthcare providers, for what we do, for realizing, perhaps even talking to patients, do you pray? Can this help you? Some people find this helpful and may feel ashamed to do it or not comfortable doing it, or don't recognize it as such as something they can do that may help them, just being thankful in the world. Again, some of this is controversial. By no means am I advocating religion for patients, but I think it's important to realize that in toolboxes for some patients may need help in being inspired to see that things like this may help them in some way, not to replace other treatments, etc. And to realize that patients, when they say they pray or don't pray, they mean various things. I think there's a lot more need for research on this. And again, I was struck by the social context of prayers, how people, on the one hand, may say, patients have told me, my mother keeps saying, well, if only I prayed more, you wouldn't have had cancer. Or if you pray more, you'll, do better. Or, well, you think praying is going to help you. It's not. So again, others are busy sort of giving advice to people, and this can be helpful or not. So in terms of provider-patient interactions, I've been really impressed with chaplains, how important a role they play. Increasingly, many chaplains, of course, non-denominational. They may offer to give prayers, good wishes, but I've been struck how they're often under-resourced and underused in a lot of hospitals and institutions. It sounds like you have a terrific chaplain here. You're very fortunate. And also I've been struck how chaplains, though, in medicine often work in a very different world than physicians, where, the doctor enters the room, the chaplain quietly hurries out, or the doctor leaves the room, the chaplain then enters. They're often not included on rounds. Again, this varies widely, often by institution, by region. So in the South, I've actually found religion plays a much larger role in communities. By South, you may hear red state, whereas in blue states and elsewhere, often, not always, religion is less a part of the community and what makes the community what it is, or communities. Many doctors don't know what to do when these issues come up. They should refer patients when appropriate. They often don't. They're often unprepared to face issues. So, and therefore ignore them. Patients may say, doctor, will you pray with us? One doctor I interviewed, for instance, was a surgeon and told me that he was wheeling a young child into the operating room for surgery, wasn't sure if the child would survive. And the parent said, doctor, would you pray for us? Will you pray with us? They were sort of gathered in a corner of the room, and he said no and left the room. He said, I'm Jewish, they were Christian, I didn't feel comfortable. He said, but afterwards I felt badly. So he asked me, what should I have done? And I said, you could have said, well, I'm happy to stand here with you. I'm happy to be with you, to pray with them per se. But again, I think a lot of doctors see religion and spirituality as bad or something we don't do. And so even when patients are saying, will you pray with us? or force. What they may really be saying is just, are you there for us? Will you be supportive for us? Do you really want to help us? And again, I think just saying, I'm happy to be there with you, I support what you're doing, something like that. If you don't believe, and doctors shouldn't say what they don't believe, I think could be helpful. Doctors and patients often also talk past each other. So, doctor, how you doing? And again, these are actual quotes of what people have told me. Patient says, I'm just hoping God, will get me through this. Doctor says, well, did you make your follow-up appointment today? Rather than, well, tell me about that. What are you feeling about that? Etc. There's another interaction. A pediatrician told me he sees this with colleagues. Doctor, how you doing? The pediatric patient says, well, I'm just hoping I'll be good enough when I meet God. Doctor can ignore her. This pediatrician who was aware of these issues said, well, I'm sure you will be. As opposed to just, you can say whatever you want. You don't have to say that, but you can say, I think doctors and providers should be prepared to have some answer rather than just awkwardly punting and ignoring it. And as I mentioned, when patients are asking this, what they may be asking is, do you care about me? Another doctor I interviewed recently told me that he had a Muslim patient who had recently come to this country and said, doctor, do you believe in God? And the doctor, who was Christian, said to me, I didn't know what to say. So I finally said, well, I'm actually Protestant, but I do believe in God. And the Muslim patient said, well, thank God you're a person of the book. Again, I think his sense was the patient was really asking, can I trust you? I'm in this strange land, in this strange country with people. And of course, many Americans fear Muslims, and many Muslims may fear Americans, given Islamophobia. And so I think religion could be a stand-in for these other things. And I think it's important to be aware of that. There's also a lot of misunderstandings, particularly with Islam, but other beliefs as well. So this is another story that a doctor recently told me. An Islamic woman wants everything done for her husband. The staff is frustrated when he's at the end of his life, saying she's unrealistic. She doesn't want to give up hope, and she wouldn't budge. A Muslim chaplain spoke to her, and it turns out she felt her husband wouldn't go to heaven unless she'd done everything for him. The chaplain told, God also wouldn't want your husband to suffer. And she was able to see that and realize that and agree that additional treatment would be futile. So again, understanding where someone's coming from could be very helpful in medical decision making. On the other hand, this is, again, patients, these are sort of from the interviews I've been doing, patients ask a Muslim doctor, Doc, am I going to die? The doctor said, well, it's all in God's hands. This is a Muslim doctor actually told me this. And he says, I feel I have to say this. It's consistent with my faith that this is all in God's hands. And he says, patients get upset at me. What do I do? I have to say it's all in God's hands. That's what I believe. And I said, well, you could say we're doing everything we can for you, which again isn't inconsistent with his belief. So again, there's a lot of, I think, misunderstanding because we often don't know much about religions of doctors and patients that are different from our own. So what should doctors say when patient says, for instance, God will take care of me? As I mentioned, these situations come up in various situations. So there was the physician who was also a chaplain, actually, who I interviewed, had trouble drawing blood from a patient she knew was religious at one point. She was trying to get the blood, and there's a little old lady who had very poor veins. And finally, she said, let's pray together. And so and the woman was very anxious, and I guess the doctor was anxious. And they prayed together, and then she was able to get blood. So the patient relaxed, she relaxed, whatever. So she signed the patient out to a Jewish physician who was then covering, told the story, and the Jewish doctor said, well, what's the prayer? What was the prayer? So again, we could sort of laugh about this, but I think we have to realize how this can help patients, calm them down, calm doctors down, especially with medical burnout. I think is another set of issues is important. And again, I think also, patients are not taught well to communicate in general. So when I did the research on when doctors become patients, I interviewed a surgeon who said that when he was about to undergo surgery in the next morning, his doctor said to him, there's a 5% chance you may die tomorrow in the operating room. And the surgeon said to me that night, I couldn't sleep. And it's only later I realized that my surgeon could have said to me, there's a 95% chance that things should go okay tomorrow. And the surgeon turned to me and said, I've been a surgeon for 40 years, and I never realized that those two bits of information that are statistically the same have such different emotional meanings to a patient. And so again, we're not taught to communicate well about these issues, about in general. We're not taught to communicate well about how we say things that may be distressful to patients, and I think we need to work on this. This is Epidaurus, which is the largest intact Greek theater in the ancient world. If you drop a pin there, I think 10,000 people could hear it clearly. And I happened to go there a few years ago, and I realized that Epidaurus, which is famous for this theater, in fact the theater was in fact part of a complex and was a center of Hippocrates, a center of Asclepius, who was the Greek god of medicine. Of course, we have the rod with the two snakes around it, a symbol of medicine from Asclepius. And in this compound was a theater, but also a hospital and a temple. And I thought how wonderful that there was a notion that if you're going to build a hospital, you should also build a temple and a theater with it. And I think that in some ways, historically, our attitudes toward the roles of religion and spirituality in healthcare have changed over time. And I think that one problem was that in the 19th century, when medicine wanted to become more scientific and wanted to distance itself from various forms of quackery, it said, well, we're science and everything else is nonsense. So religion, spirituality, holistic healing, whatever that might be, was seen as non-scientific and therefore not important. And I think that in some ways is a historical relic, because in fact, if you ask patients, if you talk to patients, as of course I think you all do, about the issues that they're facing, I've been quite struck by how patients often combine the two, how patients are concerned not just with their medical care, but also with the state of their, I'll say spirit, soul with little s's. They're facing existential issues of what does this mean? Am I going to get better? Is there something large, some larger force? What's going to happen to me after I die? Will I go on? Does God have a role here? Should I pray? What should I pray for? And I think that, what does this mean? And I think patients are often struggling, and I think the degrees to which we can be open to that is important. And again, I'm not saying, we should, quote, I actually wrote an article about this in the New York Times a few years ago about that doctors should be open to the fact that patients are dealing with these issues. And I got hundreds of responses as comments, some of which were, doctors should not be ramming religion down patients' throats. Well, I never said that doctors should be ramming religion down patients' throats. But I think there's a lot of misunderstanding and fear, and people come to this topic with a lot of pre-existing ideas and times prejudices, biases, one way or the other. And I think at least to be open to a dialogue and to help explore what that may mean, I think is important. So I think there's needs for changes in medical practice and education. Many physicians should be more aware of these issues. The fact that half of doctors at least are uncomfortable with these issues, I think is unfortunate. I think that there should be more comfort to at least be able to address these issues, or at least refer patients to chaplains if doctors aren't comfortable or providers aren't comfortable, to be aware that patients are concerned about these issues. Cultural competency has received increased attention, but often excludes religion in general and concerns patients of only other race or ethnicity. I think that religion should be part of this, and other religions. I think non-Western religions, many of us still know very little about Islam or Hinduism, though we have patients who are of those faiths, etc. Healthcare providers should have some exposure to comparative religion, to other religions, I think often in vignettes for discussion. We should be prepared to face these issues, respond when patients raise them. If a patient asks a doctor, you pray for me, or what do you believe? A doctor should have some script in their head, whatever they feel comfortable with, but rather than sort of not knowing what to say and stumbling. Right, and being caught off guard. So these suggestions may be misinterpreted, again, because of strong prior attitudes for or against religion. As I said, I'm not saying we should force religion down patients' throats by any means. Critics say doctors should not necessarily give spiritual care and are not authorities, but I think as part of getting to know our patients, avoiding pitfalls, these issues can sometimes be important, etc. And I think also, as I mentioned, we're at a pivotal point historically, I think, that public and political discourse is sharply divided, as we all know. There are evangelicals and the religious right, and this has become a political issue. There are Richard Dawkins, others against religion. And what I found, though, is that most people are somewhere in between those poles. Most patients are neither completely, this is all complete nonsense, and I don't believe anything, nor are they members of the religious right who say God is a guy in a white, not to characterize it, the white beard and a white gown and a white throne somewhere. But they're struggling, trying to figure out, that there's something, I don't know what it is. Maybe just nature goes on. It's a third law of thermodynamics. But I think to be aware of this, and I think particularly for chaplains, but for others in psychotherapy, to help patients figure out what is meaningful in their lives, I think are important. I once said to Richard Dawkins, the absence of evidence, he said there's no evidence God exists. I said the absence of evidence is not evidence of absence. You don't know what to do with that. Sam Harris has also written bestsellers against religion. He says, well, meditation alone is what we need. But I think people often also have a need to believe in something beyond them, to feel a sense of connection, whether it's drugs or through having children or something spiritual. May not wholly suffice when dealing with crisis, but can help many patients. And again, patients just a wide range of beliefs. And I think that being able to understand that can help us address political divides and help us be better providers. So I thought I'd stop there to allow room for questions. Obviously, I raised a lot of issues. Some of these may be controversial. These are some of the books I mentioned that discuss some of these issues in My Genes, When Doctors Become Patients Designing Babies. And thank you very much. And I look forward to speaking with you more about these issues in the Q&A. Thank you.
Thank you, Dr. Klitzman. You certainly raised a lot of very interesting questions. I don't know if Cheryl is also available, because I might want her to jump in and participate in this as well. We have a few questions, but I also want to give Cheryl a chance to answer some questions, ask some questions too. But first question that someone asked, it was one of the first questions that came up, is how important is it for clinicians to ask their patients about their religious beliefs? So I don't know what your thoughts are in terms of like a routine examination of a patient, an assessment of a patient. How is it an important part of the questions that you ask a new patient?
Yes, so I would say yes. I would say something non-threatening. I would say, religious and spiritual beliefs are important to many patients. Some patients are less important. What is that like for you? And understand, because it could say something about where patients are coming from. Some patients are also in religious conflict, so they may be torn about it. They may have left the church and felt guilty about it. They may be searching, wondering, etc. So I think, yes, that it's an important part of sort of the social history to understand where patients are coming from.
And one of the things that we ask here is, tell us, are there any beliefs or practices that are important to you and helping us treat you?
Yes,
and
correct.
That's a question that's in palliative care as well. We have a longer term relationship with our patients in psychiatry, as in palliative care, and understanding the beliefs that they bring to their treatment, or practices or people or connections or rituals that are important to them may not be ones that we personally believe in, but that it can help us treat them and help make their patient experience much better.
Yep, well said.
Just a follow up about that, there was a question that what do you think is the impact of the clinician's religious beliefs on their patients and the therapy? And I know you mentioned something about the Muslim doctor, but I assume there's research done on this, and the clinician, the psychiatrist who's providing treatment, or the social worker, psychologist, how their religious beliefs might affect the therapy that they're doing with patients.
So, few thoughts. So one, I would argue that the religious and spiritual beliefs of the provider really should not matter. That, right? Our first concern should be doing what's in the patient's best interest. So, in extreme case, a provider may say, "Well, I'm against abortions," but if he or she doesn't, if the patient wants an abortion, if you're the internist or something, I wouldn't say no, you can't have an abortion. I'd refer you to someone. So I would say, in general, one, our beliefs shouldn't matter. That being said, studies show that, in fact, physicians' beliefs do matter. So there have been studies on when doctors pull the plug, for instance, and it turns out that more religious doctors take longer to make DNR decisions, for instance, and are less likely to make DNR decisions on patients when given this vignette of the same patient. Same with prognoses. So there is evidence that suggests that certain more religious doctors are more likely to give longer prognoses for patients. And have their own beliefs. I think that particularly when it comes to affecting patient care, I think that's bad. I mean, the doctor's beliefs, if the patient wants, if the family's leaning toward being DNR and the patient doesn't believe in, doctor doesn't believe in DNR, that should not delay the patient becoming DNR, but evidence suggests it does. The other area where I think this comes up is in moral strain and moral distress among providers. So I have been dealing with a lot of providers facing COVID in New York City and recently in other areas in Texas and elsewhere, where there's a lot of burnout among physicians. Less in psychiatry, there's burnout among physicians and providers in psychiatry as well. So I think I would say that another area this comes up, I think that providers, if they're more aware of issues of meaning and purpose in their own lives, can potentially deal better with issues of burnout, which evidence suggests are increasing in medicine overall, and then particularly with COVID. So there was a very unfortunate situation that's unfortunately gotten some publicity at Columbia, for instance, of a COVID doctor who had COVID, got better, went back to work, and then committed suicide. So I think, feeling that there's just all these COVID patients, they weren't getting better, she couldn't help them more than she wanted to, and she killed herself. So I think that providers being aware of issues of meaning and purpose in their own lives, and therefore spiritual issues, can also help physicians in their own work, however they decide these issues, what these issues are.
Oh, very well put. I'm just trying to get to a question from Dr. Gerber, the president of the hospital. He asked, in some institutions, including Silver Hill, we have tended to group religion, spirituality, and wellness, such things as yoga, complementary medicine, expertise, and services together. Do you think that this works well, or are there drawbacks to a grouping of these things?
Right. So I would say there may be patients who are more religious in a traditional sense than others. So whereas things like yoga may work for some patients may actually, it may be important for them to go to mass on Sunday morning, right? So it depends on what you mean by grouping. So I would say that it's important to realize that patients have different needs. So if we're able to, I think what's important is meeting the diverse needs of diverse patients as well as possible. So I wouldn't say, well, we don't let patients go to mass or whatever, or go to, Sabbath, Shabbat services because, we have a unified program that has yoga but doesn't have that kind of specificity. I think that wouldn't be ideal. Again, I don't know the details of your program, but just in principle, I would say something like that, that for many patients, a unified thing is great. And so there's a little bit of debate in the field even of chaplaincy, and Sean may want to jump in here. But chaplains a long time ago, chaplains all had a particular religion. I was a Catholic chaplain or Protestant chaplain. And then there's been more of a sense of non-denominational chaplains. I think, some concerns in some hospitals in New York and elsewhere, for instance, Islam is often not part of that. Hindu, Buddhism may not be part. It's still sort of Judeo-Christian. So I think that, for many patients, a sort of non-denominational approach is flexible and can accommodate lots and lots of patients, but there may be patients who really want something more specific to their tradition.
I'll hop in here. I can't speak for every single chaplaincy program out there, but a lot of the major hospitals that do have chaplaincy programs that are credited by the APC or the SCA, they fully honor the diversity in the hospital population, and the hospital chaplaincy programs I've been involved with have had a multitude of religious traditions represented by their chaplains, all of whom represent their own tradition very well. But to be a chaplain, you have to be able to meet people where they are and be open to understanding at least the basics of anyone else who might come into your hospital, and understand that some of the belief systems, whether it's Wicca or pagan, may not be something that fits something that you were trained in, but you at least have to be open to meeting someone there and understanding why that might be important to them, even if that's not part at all of your belief system. And the beauty of the chaplaincy training programs is that anyone who goes into them could minister to a patient of any tradition or no tradition, which is more the case than not these days, at any time. And with specifically to having programs that are more open to people, like the yoga and the the more I don't want to call them new agey, but they do, some people put them under those type of spirituality programs, is that you have someone on staff, whatever hospital or program it is, that who understands where the spiritual component of that is and how someone in a certain tradition might find that meaningful. I've had patients here, we do a lot of mindfulness work at Silver Hill. I've had people who are evangelical who say, if I told my pastor I was doing this, they would, they would be very upset. And I have lots of evidence showing them, well, you can take this practice and this is how you might use it in your context. Maybe it's not the context for me, but I can give them the way to show them and have the knowledge and the knowledge base to say how this might apply to you with your belief system. And that's a lot of what the chaplaincy programs do, is they train people who are spiritual, religious generalists or specialists to be able to take that knowledge and that compassion and give it to anyone of any tradition or no tradition at all.
Yes, that's great. I should say my sense is that there is some variation across the country by region. So we're fortunate sort of in the Northeast, I think, where there is we're a big melting pot. But there are areas where if you're Muslim in a hospital, there's no Muslim, where there's less services and understanding. So I think I think what you just said is great and is the ideal. And I think I have some concerns it doesn't happen everywhere in the country.
Thank you. Yes, that actually did answer a question that someone asked, which was it an attempt to treat people more holistically? Are doctors becoming more open to faith and the need for chaplaincy? And I think that we can answer that there has been more of that. Maybe not as much. Cheryl, you may be able to answer this as well, but that healthcare hospitals and healthcare services are becoming more sensitive to the needs of a diverse swath of people from different religious backgrounds. Correct?
I believe that they are, and again, I've got back to Dr. Klitzman's point that it's my perspective as one who has lived and trained and was educated in the Northeast. So there may be some regional bias, but there are national organizations, some very good ones. There's the Chaplaincy Innovation Lab that's doing a lot of education with chaplains across spectrums very well. There is the Association of Professional Chaplains, all of whom have this as part of their ethos, and they have professional certification programs where anyone who's going through the certification, no matter what your trade or where you are, have to at least show some knowledge of how your specialty and your belief system could apply to anyone at any time. So there's more of a national movement. It's might be a little more nascent, or might be a little more unknown in some parts of the country more than others, but it's certainly there. And I think it's critical to not only what we do as chaplains, but how we work with our partners in care across the clinical spectrum.
Yeah, I should say a problem is in medicine, there's still quite a bit of resistance. So medical school deans, so the JCO, the Joint Council of Accreditation of Hospital Organizations, requires that there be something in the curriculum, but it's that's about it, right? And so it varies immensely what that is. It could be one sentence at one point. And when asked, most deans do not want more. Even if it was available, they wouldn't want more. A lot of doctors still feel uncomfortable with these issues. So Cheryl was absolutely right that there's been a lot of effort, and chaplains are great. And the chaplaincy movement, I think, is growing, but there's still a lot of resistance in sort of, American medicine with a capital M. Palliative care is one area where obviously it's been more widely accepted and it's become really integral. But I think there's still quite a bit of pushback, sort of, and suspicion of all that religious stuff, quote unquote. And again, I think there's an in between that's the right balance. And I think people often feel that's there's an article in the New England Journal of Medicine a few years ago. Doctors should not prescribe religion. A tirade that doctors should not prescribe religion. People aren't really saying you should prescribe religion, but I think you should be more open to it.
Thank you. There is a question that I think you kind of addressed briefly, but it's how to handle an issue with a patient when there's a problem with a patient that conflicts with the provider's spiritual religious beliefs, and they give examples of adultery or abortion. And I can think of a specific example from my own personal life how we had a patient come in, and we found out during her time on the inpatient unit that she was pregnant, and a nurse on the unit said, "I refuse to administer antipsychotic and mood stabilizing medication to this patient, even though she was there because she was having a psychotic episode. And if she hadn't taken the medication, she could decompensate, she could die." So we just found another nurse who didn't have an objection. But I imagine there are situations that arise in small community hospitals where a physician or a nurse refuses to provide care in a situation like that. So, I mean, as an ethicist, is this something that's there's a way to address this when these kind of ethical issues arise?
Yes, so ethically, there's, quote, conscientious objection. So someone could say, I as a surgeon, I as a physician don't feel comfortable providing abortion, or I've not heard that case specifically of not wanting to give the antipsychotic medication. But what's important is that the provider then say, but here is someone who can do it. So I may not be comfortable, but here is a doctor who will be able to do it if you'd like. So I think that is the issue. Now, of course, what happens in small communities, especially, abortion's a whole other topic, right? Where there is, pro-lifers who are trying to, diminish the availability of abortion services. That to me is personally horrific. But so I think conscientious objection is ethically allowable, but there needs to be, for the patient still needs to get the service that is appropriate for that or what he or she wants.
Yes. And so I also think, it's interesting because we've gone very far to try to respect the religious beliefs of patients. For instance, Georgetown v. Jones, the famous case about Jehovah's Witnesses and getting blood transfusions. One of my first cases as an intern at Mount Sinai on the medical service was a woman with Jehovah's Witness with really very serious anemia, and we respected her wishes to not get a transfusion, and we were able to treat her while respecting her wishes. But the next question is one about, do you think that medical schools are out of touch with the American public and showing resistance? I assume that she means resistance to teaching about religion and spirituality. I can tell you personally, this was not covered in my medical school. So yeah, maybe things have changed at Columbia, other places.
No, that's probably why I've been working on this. So I think there does need to be more change. As I said, the fact that, roughly half of doctors are uncomfortable talking with this topic about patients, and when asked why, they say, well, the patient would be uncomfortable, I think is factually incorrect. That the patient would be uncomfortable. Other studies show, when asked another reason why doctors don't discuss these issues more, is to say, well, they don't have an appropriate place to do it, which I think also doesn't make sense. So I think, doctors are uncomfortable, and I think a lot of that is because there are misperceptions about religion, spirituality, and the role thereof. I think there's also been a change over time from, if you just look at church attendance in the US, it's any religious institution attendance, overall it's dropped precipitously. That being said, there's been a rise in evangelical church attendance, so a decrease in other church attendance. But I think that medical schools do need to pay more attention to this. There's been some effort, but as I said, not enough. And actually, what Jaco says is students need to be taught about the value of getting a religious history, but not about how to get a religious history, right? So, and I think even that, I think the language that Cheryl used, for instance, suggests, I think there are ways of asking about it that we need to do more about.
Absolutely. I don't know if Cheryl, you have any questions or things you wanted to ask Dr. Klitzman at this point.
The one thing I might add, and it's a reflection of some of our demographics at Silver Hill, maybe not national demographics, but I think it is trending nationally too, the rise in the spiritual but not religious. And Dr. Klitzman, you hinted at the precipitous decline in church attendance, which again, 2 generations ago formed a large component of society. That questions of existence and meaning and purpose have always been there, but people had more of a societal place to process them. Now we have patients who have these questions and no place to process them, and many doctors who come from similar demographics who also aren't holding beliefs or bricks and mortar institutions as the paramount thing and a good number of their lives. So I hate to say you have the blind leading the blind, but in a life crisis, in a bad medical diagnosis, questions of meaning, existence, and purpose, and how you're going to have a belief system or a spiritual practice to help you cope with this are still very critical. So I think opening it up in light of the changing demographics, however we can do it in medicine, on an institution by institution level, which we certainly do here at Silver Hill, but having a place where these questions can be processed when they're not being processed elsewhere, and having people who can say, I'm supporting you wherever you are, is very vital to care in the 21st century.
Yeah, absolutely. I'm curious from your points of view, I mean, where are there challenges in this realm? In other words, do you see the particular kinds of cases where it's been unclear how to address these issues, or difficult to address these issues, or more could be done perhaps?
From my point of view, working in psychiatry and having done my training in a larger hospital, I think you have 2 ends of the spectrum. You have a place where you have it so watered down and so, something for everyone that it fails to have an impact, or you have something that gets too belief-based and people, many of whom really have a need, say, this isn't for me, I don't want it. So I think it's finding a happy medium in your programming, in your training, which again, I think a lot of the chaplaincy programs are doing, in the hospital's programming, that anyone could feel that this would be something that they could enter into, both as a clinician and as a patient.
Yep. And you mentioned, I think before we chatted briefly, you see more and more of people who are spiritual but not religious. In fact, that number it's doubled over the past 12 years or so. I think from 13% in 2007 to sort of 26% in 5 years ago, the people who say that they're spiritual but not religious, so particularly young people. So I think there are these shifting demographics, and I think also as those people get older, I'm not sure what's going to happen. I think religion helps many people, especially when they're facing death and dying. And I think that will be a challenge for us as clinicians and also patients. But even as patients get older, if they were not raised with something to fall back on, I don't think they need that necessarily. But I think having a framework for dealing with these issues or thinking about them, I think may pose challenges for some patients and clinicians.
I agree. I mean, it's something we work very hard at here, but I agree that it's a growing challenge, and how the pandemic will, no one knows. The great unknown, and the people who follow these things, is what will happen once the pandemic is over and people can return to a bricks and mortar community, how that will change. Will attendance, which was already dropping, come back? And it's a great unknown, and how churches and religious leaders and even other, spiritual communities have stayed together through this. we will see what it looks like in a year. I don't know.
I think a lot, just as so much has been converted to Zoom, and there's Zoom religion now, right? And e-religion, a lot may not go back. I mean, there are older patients I've interviewed who say, you know, they sort of lied, but they don't have to go to church on Sunday morning. Their ministers, they're on their computer right in front of them. They can see him better. They can hear him better. They can sit in their bathrobe and drink their coffee during the sermon. You know, so I think a lot of that are things that people may stay with. So I think things won't go back entirely to life as it was before, but to some degree they will, but not entirely.
Well, I think we're done with the questions, although I do want to say that one of the things that came up is asking why do you think there's so much resistance? And I think, you know, we were taught, I mean, I was taught at least, you know, you don't talk about politics and religion, you know, the old saying. And I was one of the interesting things, you know, having a father who came from Iran and was an immigrant here, and you know, people didn't care about his religious beliefs. And when, you know, I'm working at Jewish hospitals, where I've worked at hospitals with their non-denominational, people don't care as much about the religious beliefs of the doctors, and the patients say, well, my religion shouldn't be a, you know, concern for you either. Obviously, we know that it can affect someone's health and well-being, but maybe the issue is that they don't want it to interfere with the treatment they're getting. Although my last question to you, Dr. Klitzman, is, you know, the one issue, I don't know if Cheryl, you've noticed this either, but the one area where people complain is that they think that sometimes AA is too religiously oriented. And I get people here who are, you know, pretty staunch atheists or agnostics that's like, I don't want religion creeping into my treatment, as if it's not as valid a form of treatment if there's a religious tilt to it. Although we always try to explain to them that higher power can mean many different things, but I don't know what your thoughts are about AA and how that you know, spirituality and religious aspects of AA and how that people have complained about that. Or
you're asking me or Cheryl?
No, I'm asking you, Dr. Klitzman. Sorry.
So I would say, as you suggested, it depends on the definition of higher power. So, you know, I think, you know, I've had patients, you know, who are, you know, I have one patient, you know, grizzly old guys, you know, with alcoholism in the hospital, you know, dying of liver disease, saying I was a mean son of a bitch my whole life, I don't believe in anything, and then saying, you know, was there anything you want to do before you die? Oh, I should contact my kid. Well, why don't you contact your kid? I mean, I hadn't been in touch for years, for instance. So I think ultimately, I think it's deeply embedded in all of us evolutionarily that we have needs for connection to something beyond the mere material aspects of our lives. That could be a principle of helping others or something like that. And so I think that most people, if you define higher power in a, I'll say, secular term, feeling awe before the mysteries of the universe. I mean, it's a little less purely secular, but I think that, you know, I, you know, interviewed one patient who was an astronomer and said that, you know, he, a strict atheist, but then said, you know, the reason he got interested in astronomy was when he was an adolescent, once like staring up at the night sky and all the mystery of the planets and stars just left him sort of wondering what all that was. So, and that's what led him to go into astronomy. So I think a sense of awe even before the universe, I think things like that, a sense of there's something larger than just you as an individual. I think even in secular terms, there are ways of thinking about, quote, higher power could just be, you know, higher than you as an individual. It doesn't mean higher than, higher than what, right? So I have to think about it a little more, but I think there are ways of saying it doesn't need to be God. And I think that finding what in a patient's life is something that gives meaning and purpose, and appreciating that, I think those are having that conversation, I think, could help patients. I mean, some patients who are vehemently anti-religious, often it's because they've had a bad experience with religion. You know, their parents were evangelicals or whatever, or Orthodox, whatever, you know, Orthodox Jews. And so they're running away from that, but that does, so they may think, well, that if that equals religion, then where I am equals no religion or no spirituality. I think that's a mistake. In other words, they may say, well, I don't want that, and they may think, therefore, I don't want anything. But in fact, there may be something that they, in fact, find is a source of meaning or purpose in their lives that I think we as clinicians can help them find, and that may be helpful therapeutically for them.
And I'd say doing what I do, probably 20% of my consultations are people who have some challenge with either AA, with religiosity, with spirituality. And when they see that you're not there to argue with them, you're not there to combat them, you're not there to give them a belief. You're just giving them, finding something unique to them that can keep them going in a program that might just be sustaining them. Once they realize that you're not arguing with them, and that you have no intent of having any argument with them or giving them an epiphany or a conversion or anything, it's amazing how quickly they back down and they can become a lot more accepting of what might be in the program for them and how they might define spirituality for themselves.
Yeah, so I interviewed an elderly chaplain recently, told me she was, knocked on the curtain of a patient's room, and said, I'm from the chaplaincy service. No, go away, we don't need you, we don't need you, the man said, the patient. It's all bunk. And his wife said, no, why don't you come in? Why don't you come in? And so the chaplain said, thank you. So she said, I can either give you a prayer, I can just give you good wishes. So shall I give us good wishes? The wife said, and she said, okay, I just wish that, the surgeons have all the skill they need to help Joe, whatever his name was, in the morning, and that his body's able to heal as best as possible, and the anesthesiologists have the strength to help you as much as possible, etc. And at the end, he grabbed their hand and said, yes, yes, yes. So I think that even though he didn't want to talk to her, and it's all, bunk. So I think we have, because these terms, chaplaincy, God, higher power, religion, spirituality, prayer, grace, whatever it is, can be defined in different ways. People often have a definition when you use the term of what you mean, and feel that that's not me, that's not how I would define it. And so they reject your definition and therefore reject the term without realizing that there's something in this space that's still meaningful for them. So I actually think the word chaplaincy is a bad term. I think chaplains too often, people live in the chaplaincy service and people go, I don't want a chaplain, that's going to be someone with a white collar, right? And of course, as Cheryl was saying, it's not modern chaplaincy, but I think that people still have these preconceived notions of what these words mean, and that could sometimes get in the way of, I think spiritual counselor or I'm from spiritual services or something like that, or maybe ways that for some patients may be more, speak to them more.
Wonderful. I don't know if I know that Dr. Weiner had been involved in the call, or was going to be involved in the call. I don't know if he has any comments or questions. Cheryl, if you do, but if not, I was going to just thank Dr. Klitzman for coming on today. I really appreciate this. Was a really stimulating talk that was covered a lot of controversial areas, but I think you handled it really well. Thank you so much. For those of you who want to get on and get credit, you go to the published section of Q&A and just click on that and click on the link, and you'll get connected, and you can submit your continuing education credits. Thank you so much for everyone who participated.
Thank you. Bye-bye.
Thank you.